Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you from Tehran, and once again I'm so blessed and honored to have the chance to share this educational platform with all of you from around the world, with great and amazing educators and speakers from around the globe, which I'm so blessed and happy that they accepted to join and share their knowledge, their expertise, and their experience with all of us for making us obtaining better knowledge and understanding in treating our patient. And today, a super talented surgeon, a great educator, which I'm so blessed she accepted to join, is here with me in this platform. Professor Devorah Schwartz, Arad from Tel Aviv, is here with us. Hello, Devorah, and welcome to Hot Seat, my friend.
Hi, thank you, Omid, for inviting me to this distinguished Zooming lectures. I hope we have the chance to meet now when vaccination is getting better in the world. So I'm looking forward to see everyone in real life.
Yeah, me too, my friend. And I'm so happy that you accepted to join because, you know, for all of you, I think most of you are familiar with Professor Schwartz, Arad, with his articles, with her articles, her publications, her presentations, and all amazing things that she do in oral maxillofacial surgery and implant surgery, a unique personality and inspiration for so many people, and a leading woman in the field of perio and implants. So much energy here now during this time, I'm pretty sure for so many of you like me. And before we start the presentation, which is actually one of the most demanding topics in the field of perio and implant, and that's the concept of treatment in atrophic maxilla that Professor Arad accepted to present it for us. Before we start, I would like to have a short CV of Devorah for all of you, and then we will go through the presentation, and for sure, at the end of it, we will have a great discussion on this amazing topic. Dr. Schwartz Arad is a specialist in oral maxillofacial surgery with a PhD degree in cancer research, anatomy, and embryology. Graduated from the Faculty of Dental Medicine of the Hebrew University and was a senior lecturer in the Department of Oral Maxillofacial Surgery at the School of Dental Medicine in Tel Aviv till 2008. Since 2016, Dr. Schwartz Arad is a research professor of the Pharmacological Research in Dentistry Group at the Faculty of Dentistry, State University of Granada in Spain, and also visiting professor at UCAM in Spain. Dr. Schwartz Arad is the author of more than 78 research papers focusing on immediate dental implantation, bone augmentation procedures around dental implants, and influence of smoking on success of dental implants. She also presented more than 100 papers in scientific meetings, and she's a renowned national and international lecturer. She's the author and editor of the books Reach Preservation and Immediate Implantation and Aesthetics in Dentistry, published by Quintessence, which I truly, truly recommend you all. If you're a fan of implant dentistry, you should read these amazing books by her. Also, she's the founder and president of Conflict and Dialogue Study Club, and she's heading the Schwartz Arad Continuing Education Center. Also, she's the owner and senior OMS of Schwartz Arad Daycare Surgical Center. And there is a famous phrase, I think, by you, my friend, that I wanna read it here now because it's truly a moving sentence by you. And that's, dentistry should become a domain where expectations are set by personal knowledge, wisdom, and artistic talent, and not by stereotypes. We've got to get women dentists to stand on stage, which I believe is truly an inspirational sentence by you and a great message. So, my friend, we are ready from head to toe to hear your beautiful presentation and looking forward for the discussion at the end.
Thank you for the long CV. And I would like to just start now, and then we'll have a discussion. So I will share my screen now, and actually, Okay. It now. Is it okay? Is it okay, Omid?
Yes, it's perfect.
Okay. Okay. Actually, what you see now is the entrance to my surgical center. This is situated in north of Tel Aviv. It's a nice spot. Actually, it's an area of medical centers. And we are a building that we have clinics and other centers, and gastroenterology, eyes center, etc. And actually, we have two operating theaters, and you can see the pictures here, the two operating theater authorizing by the Ministry of Health in Israel for mid-level surgery. It's a daycare surgical center. And actually, oral and maxillofacial, we are 3 oral maxillofacial surgeons are operating here, plastic surgeons, ENT, dental care as well. So it's quite busy. So after this long, I will start from oral to facial, concept of treatment in patients with atrophic maxilla. So facing forward, actually, it's our motto, taking holistic attitude when we look at patients. And when you look in those 4 patients that I show here, you can immediately see that we have a few problems, not only teeth problems, but aesthetic problems. And as we can see here in our center, is to see it the face as a holistic treatment options, not only to give back function, what we do today sometimes, but also to keep with the aesthetics and to support the face, the soft tissue, facial tissues, and only then they can go to the plastic surgeons and to do some more operation if needed, because of aging. So we're talking about 2 important things. First is the loss of teeth and atrophy of the, I will talk today only the maxilla, so the atrophy of the maxilla, which leads to the facial problems that we see, the lack of support of the upper lip and cheeks. But there is another thing that you can see in the second patient, that the nose, the tip of the nose is really dropping down. It's a droopy nose, not because of genetics, but because the loss of support and the loss of bone. So I would like to talk about 2 of these women and to explain the concept that I believe today, which is true to get to the goal that I was talking about, supporting tissue together with functional and bringing back the function and aesthetics. So you're all familiar with the facial aesthetics proportion. Just to remind you, the vertical and horizontal transverse proportion of the face. So usually, if we look in the profile view, we have 3 important, if you look in the lower third of the face, which are the lower third is the one that we are interested in when we are dealing in maxilla and mandible. So we have the nasolabial angle. The nasolabial angle is important since it is influenced mainly by the position of the upper teeth, but not only the teeth, also the position of the maxilla. Also, the same is true for the lip position and the fullness of the upper lip. The labiomental angle and the lower lip is mostly influenced by the lower jaw and the lower teeth. The vertical proportion, we know this 3/3 of the face, both in the vertical and the transverse proportion. So we have this proportion, but we have other proportion like 1/3 and 2/3 from the nasolabial area to the middle of the lips and then to the chin. And then we have 2/2 if we decide to do different cutting in the lower part of the lower lip. So we have to look at the proportion of the facial of the patient before we start treating them. And of course, we ask them to bring pictures, sometimes because they were at class 2 or class 1 or class 3, and we want to give them back the normal look that they had in the past. So as I said, we'll talk today about maxilla. So the topic of my lecture will be the maxillary atrophy, pseudo or what we call acquired class 3. And the second is a treatment concept, and I will talk about phase A and phase B. And I'll show you what I mean by the new and novel treatment concept. If we'll talk about the phase A first, so it's very important that to bring back the position of the teeth in the right direction. Let's say now let's talk about the class 1 patients. So in order to be able to place implants, we need first to do augmentation procedure. So the easiest and most predictable way to get a vertical augmentation in a very predictable way, it's sinus augmentation at the posterior part and subnasal elevation procedure in the anterior part. This would give us option to place implants in a very predictable way. The other way, still in phase A, we are talking about horizontal augmentation, since the atrophy pattern is both vertical and horizontal. So the horizontal augmentation for implant placement, I do through intraautogenous only bone grafting, which I wrote a lot about it, which I harvest mostly from the mandible, from the ramuses, and sometimes from the symphysis. And then simultaneously implant placement, but the position of the implant, as you will see later on, will be in such a way that it won't influence it will support the lips and cheeks. Let's just see the first patients. I will tell you the truth. These patients didn't want to go through phase B. So I brought her just to show you what I mean by phase A and to see the disadvantages of not doing phase B, which we will see in the second patient, which we did everything for her. So this is the first patient. She looks older than her age. She's 54 years old. She had severe maxillary atrophy, what we call acquired class 3. She was class 1 to begin with when she had teeth, and she has teeth in the lower jaw. If you look at the intraoral view, you can see a very neglected situation, and the problem immediately, you can see immediately the problem that she used a full denture, but in a very poor solution and a very poor aesthetic solution. Looking at the maxilla in the panoramic CT view, I would like to show you a very interesting phenomena that happened with age. We all familiar with the pneumatization of the maxillary sinuses with age and with atrophy, but you are less, but most of people pay less attention for the pneumatization of the nasal cavity. cavity. And when we look here at the anterior maxilla, for instance, one can see here that we have, if you see my cursor, do you see my cursor? Okay, good. This is the basal bone and the alveolar process. This is the nasolabial canal and the floor of the nose, okay? If we go, and of course, this is the nasal floor. If we go posteriorly and to the middle area, look here, still with the nasal floor, we're going back almost at the area of the molar teeth, and only the maxillary sinuses are back in the posterior side. So the pneumatization goes both for the nasal cavity and for both sinuses. So if we would like to place implants, sinus elevation procedure will not be sufficient for placing implants in the anterior, middle, and even a little bit in the posterior area. So we have to do subnasal elevation procedure, which I do often in such situation. If we look at the intraoral and the panoramic view, you can appreciate the amount of missing tissues on the horizontal dimension. This is a severe acquired or pseudo class 3. How do we treat class 3 usually? Sorry, let's go back. And so the first phase will be augmentation procedure. So as I said, subnasal elevation procedure in the anterior and middle area, and sinus elevation procedure for horizontal augmentation, but not for to cover all this discrepancy, just to be able to place implants. I do the autologous only bone graft harvested from the mandible, and simultaneous implants placement. So let's see the first phase, the phase A. So mid-kerstal cut is done, and then this is the subnasal elevation procedure. I use piezo device for the maxillary augmentation procedure, both sides, on the right and on the left side. You can see here that I ruptured the Schneiderian membrane, and I'll show you how I corrected it. And this is on the left side. I use the lateral wall to place it back. This was done like 10 years ago, so I used a conventional template. Today we do it, of course, digitally for placing the implants in the middle and posterior part. And this is the subnasal elevation procedure with bone marrow harvested from the iliac crest, mixed with bioos. And this is how I harvest the monocortical bone from the ramus to build up the entire anterior maxilla. I take another block, and then I harvest more from the symphysis. Since I needed more, I put the wall of the sinus back, and then I fix for horizontal augmentation. I use a lot of xenograft material saturated either in PRP or in bone marrow. This is releasing off the periosteum, and this is not a membrane. This is a plasma, PPP, platelets per plasma. Look at this. This is a buccal fat pad. I always use a buccal fat pad. This is a pedicle graft used for vascularity, volume, to protect the entire augmented area. And then layer suturing without tension. So this was the first phase. If we look at these slides, you can see here the rupture that was fixed with PPP, platelets per plasma. This is the subnasal elevation before filling material was placed. You can see here. and after implantation, sinus elevation procedure, augmentation procedure, and subnasal elevation procedure. Of course, implants were left buried, and then I used the buccal pad of fed. I would like to talk a little bit about this buccal pad pedicle graft, or what we call the Bichard. In oral and maxillofacial surgeons, all knows, I don't know how many oral and maxillofacial you have in my audience now, but when we do orthodontic surgery, we always didn't like to meet this Bichard pedicle graft. Nevertheless, I learned to use it both in orthodontic surgery, in atrophied maxilla, and also in the augmentation procedure of atrophied maxilla. It gives three important things. First, it gives vascularity, fantastic vascularity, because it's a pedicle graft. It's not a free graft. Second, it gives volume for the cheeks. Third, it protects the augmentation, the augmented area, because the most important thing is not to have dehiscency over the grafted area. Because I don't use denture for 3 weeks, but later on, if you don't have how to, she cannot walk for 6 or 9 months without the denture. So we give a denture with soft lining. Sometimes I do implants, temporary implants, even zygomatic implants to hold temporary prosthesis. But nevertheless, this graft I do every time. This is important, and one has to know, of course, surgery to use it, but still, where do I take it from? This fat lies in between the masseter muscle and the buccinator muscle. If we cut the buccinator, here you can see it's a big pedicle. So when I penetrate from inside the buccinator through my incision, I pull it over very gently, as I showed you, and I show you in the next patient as well. So this is immediately after operation. You can see the screws holding the blocks on the anterior area. Of course, you can see the implants and the huge amount of bone that I used for subnasal elevation procedure and for augmentation, vertical augmentation, sinus augmentation procedure. One can see what we talked before when we looked at the CT scan. This is a subnasal elevation procedure. Look till how we got to very posterior part. This is almost the molar area. Again here, look here. This is only the area of the sinus. So I did a little too much, yes, that's true. But now you can see very clearly the anatomy. So there is no way to put implants here in longer than a few millimeters without subnasal elevation procedure in a very atrophied maxilla. So this was the first phase. Today, we scan the implants at time of the first surgery, and we prepare already the transitional prosthesis for the second stage. As I told you, this was done almost 10 years ago, but I want to show you the long-term stability of the procedure. So it was important to me not to bring just new cases. And so we waited 9 months, and then we adapted her denture for the first fixed denture that she had for years. So this was 9 months later, the uncovering. Still, we're talking phase A, because this is uncovering. I prepared it with multi-unit abutment, one abutment one time. I do some connective tissue manipulation here, free graft from connective tissue graft, to give more volume to the buccal area, and then fixing the denture and adapting it to the multi-unit abutment for the transitional denture. She will go with this transitional denture for a few months before we decide whether to go to phase B or going to fixed denture. So here we can see I took a biopsy, a sample, just to see. Remember, these are the bone, this is the bone graft that I placed here. And I'm always curious, of course, they agreed at time of uncovering to take some of the, just a sample here. And one can see here, and this is repeatable, that we can see here, this is the dark red, the dark purple actually, is a new bone formation. And those are the remnant of the bios, of the biomaterial that I used. So we can see here that there is a lot of new bone formation in this area. So the use of monocortical bone together with bone substitute harvest and saturated in PRP or in bone marrow is a predictable augmentation procedure. So we started this way, and this was after, actually this is a final restoration, and this is final. Unfortunately, she didn't want to go to phase B, as I told you, and she was quite happy with the result. Here you could see the buccal cantilever, the huge buccal cantilever holding and supporting her upper lip. Okay, of course I put some implant on the lower jaw, but we're not talking here. So, and if we look, this is 6 years later. This was taken 6 years later. We can see quite a stable bone. I didn't place implant here. I usually don't, since if they don't do the second phase, I don't want implants in the area where they will need, where we need the cantilever, since otherwise it will be impossible to rehabilitate the implants that we will be placed in, actually in class 3. So I hope you can follow me. This is the final work 6 years later. And well, people might think that this is great results, but I would like to say I'm not quite pleased, not because of the prosthodontics. The prosthodontics, I'm an oral maxillofacial surgeon. I'm not going to say anything about prosto. I mean, if it's good or not. I'm talking the holistic way, how to look on the face. And let's see the face now. And this is how we started. And this is 6 years later. Okay, so we managed to bring her to class 1 quite nicely, I would say. But still, look here. If we want a fixed denture on implants, it's the same for the all-on-4, on zygomatic and others. You need huge cantilever. And in order to be able to clean it, you cannot really place here pink prosthesis to support here, because otherwise there is no way that the patient can clean it. Only removable denture can offer a support in this area. So if you look at her face, and she sent me here and allow me to show you, she's very happy. This is 6 years later, actually, but I'm not so happy. Why? First, I don't like here because it's not enough supporting this area. But if we look closer, when she talks, look what happened to her upper lip. We have this unpleasant smile, I would say, because of this upper lip wrinkle. This also causes a flabby lip and sometimes a droopy nose. So, how we correct a pseudo or acquired class 3? I would ask you a question if I would give you a lecture. How do you correct a natural born class 3 due to a small retruded maxilla? We have other class 3 because of mandible. I'm not talking about this. The operation For class 3, severe class 3, genetically class 3, due to retruded maxilla, is Lefort-1 operation. Lefort-1 osteotomy, advancement, down fracturing. That's what we do for class 3. Suddenly we have a patient with class 3, acquired class 3, but we don't think about operation. We give her four implants, we call it all on 4, and then we give a huge cantilever. She's 54, I remind you, and we are happy. But we gave her function, and we didn't solve the cosmetic problem, the aesthetic problem. Neither we might not be enough with those 4 implants for the long run. But even if it does work, you've seen even with more implants, with augmentation procedure in the anterior part, we have still some problem. So today, even the international, the ICD-9, which is a statistic, which is international statistical classification of diseases and related health problem. It comes from the WHO, from the medical classification listed by the World Health Organization. We all use it in the word in our operating theater. We must use the ICD. This is the ICD-10, which is the most modern, written in 2017. Look what they say. Even in this classification, they accept acquired class 3 as even partial, complete or partial, due to loss of teeth. So it means, this is from insurance reason, it means that if you decide to treat class 3, which is acquired even not by complete edentulation, just partially edential, you can treat it in the right surgical way, which means orthodontic surgery. So this is actually the ratio before offering the patients to begin with. When you have not a small discrepancy due to light atrophy, but severe atrophy, when you have more than 3 or 4 millimeters of atrophy, of horizontal atrophy, and you cannot overcome it with augmentation procedure, then you use the Lefort-1 osteotomy. If we look at the Lefort-1 osteotomy, which we call the phase B, this is well known now. This is well, quite old now, from 2014, written by several oral maxillofacial surgeons, that in the nose, cheek, and upper lip area, the greatest changes were seen in Lefort-1 group. So we know that the best operation for supporting the lips, cheeks, and nose, when we have retruded maxilla, either born as or acquired, is by advancement Lefort-1 osteotomy. So that's why I called the lecture From Oral to Facial Surgery. So now we have to decide why actually not to do it all together. Why not to do Lefort-1, place an inlay from the iliac crest and implants all together. So this was how they started with the Lefort-1 for the management of severely resorbed maxilla. Nevertheless, I believe in accuracy, and you cannot get accuracy if you don't have teeth. So I want to mimic the situation of the normal, let's say, born class 3, when we have teeth in class 3. So first I'll place the implant in class 3, and only then I can accurately place the bone in the right position. I'm not so worried about the vertical dimension because we can replace it with pink prosthesis. I'm worried mostly about the discrepancy, sagittal discrepancy that cannot be overcome with this pink prosthesis, as we showed in the first patient. So phase A would be, first place the teeth. That's why I call it teeth first. Now I'm writing the chapter for the first digital book that are coming with the DDS. So it will be called teeth first. So everything that I tell you will be written, I hope in few months, by quintessence in my publication in this digital book. Nevertheless, phase A would be first place the teeth. How do you place the implant? You have to do the augmentation implantation and then do the Leafort 1 maxillary advancement accurately, because you know how to make it from class 3 to class 1 when you have teeth. So we need actually two prostheses. One that will be used in the operation in class 3, but you cannot send the patient in such discrepancy with the prosthesis that will not support the lip. So we prepare two. One in class 1 with a huge cantilever just to hold the face till we can do the operation. And then we do the second one in class 3. I'll show you in a minute, so it won't be just talking. Okay, so let's see this lady. This lady, when she walked in the clinic, she looked like a supermodel. Very tall, very nice, and only 39 years old. She a past smoker, but she was not smoking anymore. And actually she had a past of long treatment in actually in the what we had in the past USSR in Russia. And after that she came to Israel, and then she could afford treatment. But let's just see this fantastic lady. So when we look at the proportion, as we started the lecture, she has a little bit square face, it's okay. Middle 30 slightly decreased, but as a whole, she has quite nice proportion. Nevertheless, if we look at the profile view, if we look at the yellow line, she has a straight profile. Tip of the nose is droopy, it's a little bit down. We have a very sharp nasolabial angle and lips position and fullness. She has very nice lips, so you don't see much of the problem in the upper lip. I always check the gonial angle. Since if this is normal, I know that the problem lies in the upper jaw, but we know it when we look at the x-ray that you will see immediately. She has thick lips. When she smiles, look what happened. First, she showed most of her crowns, the clinical crown length, almost 100% of it. And also, we have a smiling deformity, the nasal tip depression. You can see it. I'll go back. Oh, you can see here the problem. But when we look at the panoramic view, remember, she's 39 years old. She's not sick. She's a healthy human being. And the problem lies in, I think, in the treatment she got and smoking, of course. But when she came to me, she had a very, well, I say, lots of experience with lost implants. When I look at such a patient, a young patient, and I see implants, I don't think I can do better. I have to think why everything fell down, why she is such a disaster, a dental disaster. And I think one of the problems is not taking the holistic situation they didn't take it into account, because they were just placing implants. They did they did sinus elevation procedure and placed implants. And this is not always enough. Look at here. She has you can see here, it's not a broken implant. This is an implant that is lost, but here we have another implant that was broken from the past. One implant is not used, and this is all lost. If we look at the profile of the cephalometric view at time of referral, and we look at the CT profile, I would like you to pay attention. You see here the denture that she came with, okay? The prosthesis, the fixed prosthesis that we saw here. You can see it here. But the tip is here. This is the incisal tip. And actually, here is the anterior nasal spine. Look at the huge discrepancy between the implants and the tip of the anterior tooth. Of course, this cannot be, it cannot hold for the long term. This is huge cantilever. And actually, I like the position of the teeth here, because this is what happened, hold her upper lip. If she had her teeth here, she would look as a disaster, but the implants couldn't be saved. Look here, this is a position of the anterior incisor. Huge discrepancy. This is the scanning of her face at the same time. And you can see here the problem that we talked about. Even if she carry the prosthesis here and here. And this was a time, the first day, this was implant that she lost. And this how 2 implants, we had to just remove them. This is at the first day. So the prosthodontist just helped her. I'll show you again. Help her, I took the implants out just like this. Okay, you can see 1 implant and the second, and we placed back the same prosto that she had, just with some refill. So we don't have an implant here, we don't have an implant there. We used this implant that was buried. We couldn't use this implant because it was broken screws that we couldn't remove. And here you can see very clearly part of the old implant that still was there. And she still had this wisdom tooth, which we decided to keep, first for the transitional and second for the vertical dimension, for vertical stop, for posterior stop. Look at her before giving her the transitional. Look at the huge discrepancies, the severity of the pseudo class 3. This is a real problem. Those are the dentures. Those are the dentures that she carries, 39 years old lady. Look here. This is the wisdom tooth. Of course, it's a mirror look. And this is without the teeth. This is the true look of her. This is actually the true look of her. The loss of support, tip of the nose, and loss of support for the cheeks. So we look today at these 3 very important areas: the nose, the tip of the nose, the nasolabial and upper lip, and the cheeks. Now we start to plan what we are going to do for her for the first phase for placing implants. So we did everything digitally. And actually, I liked, as I told you, the position of the upper incisors. So we kept this position almost in the same way that she had in the old prosthesis. And then we tried to build up prosthesis. And then we actually moved the maxilla forward in order to place the implant. I mean, virtually, we moved it forward in order to place the implants in the correct direction as they will be after the Le Fort 1. To overcome, we actually took this backward, but it's the same way. So we can see here the virtual position of her transitional prosthesis with the true class 3 position of the same teeth, just moving back, okay, like moving forward the maxilla. It's the same. And this discrepancy is a discrepancy that we have to overcome in the anterior advancement after Le Fort 1 operation. So we start to place the implant virtually, and you can see here the old implants in red and the new locations that were prepared according to the future class 1 position of the teeth. Now, the first operation, of course, we used a template prepared for us digitally after we prepared the location. And you can see here 2 transitional implants for the meantime that I placed in the meantime. And now we are doing the phase A. I harvest bone marrow from the iliac crest, subnasal elevation procedure, both sides. I needed sinus elevation procedure only on the right side. On the left side, I had enough from previous operations that she had. And here I placed the implants simultaneously, several of them. I took another implant that were lost. I placed the implants, harvest bone from the symphysis. I choose a symphysis since we needed to take some implants away from the mandible as well. This is the anterior augmentation via bone graft, now covered with PPP, platelets, poor plasma, and this is covering the donor site, filling it with bone substitute harvested in saturated in bone marrow and covered with PPP. If we look at phase A, vertical and horizontal augmentation, as we saw in the first patient, sinus and subnasal augmentation procedure, together with autologous bone graft and simultaneous implant placement. I didn't place all the implants since I needed more augmentation on the right side, but most of the implants were placed. We can see here, we loaded one of the implant. This is transitional implant, which will be replaced later on. Those are the final implants. Look at the difference in the position of the old implants and the new straight implants. Actually, this is actually what I believe was the reason for the loss, because they were obliquely situated buccally to overcome the huge cantilever all over the atrophied maxilla. You can see here this subnasal elevation procedure, both sides, and sinus elevation procedure on the right side. This was already done by my colleagues prior to this surgery. You can see here, those are the implants. So this is one of the 2 prostheses prepared for her. This is the transitional prosthesis that served her in the meantime till we uncover the implants and we'll go to phase B. She can talk, walk, and go with them. So one can ask, what's wrong with this? Just leave her alone. Now make the final prosthesis and it's enough. We have enough implants, we have a nice prosthesis. You overcome the vertical deficiency with pink prosthesis, also the sagittal. Let's see if it's true in the aesthetic point of view. Look at her. This is a pre-op, okay? Remember it, okay? We saw it just a few minutes ago. Now, let's see with the new prosthesis post phase A, after augmentation procedure in immediate implant placement and augmentation procedure in the anterior area to overcome a little bit of the discrepancy on the horizontal dimension. when she smiles, no change at all. She still has the same problem that she had before. I cannot overcome those problems with a block graft, which is maximum 4 to 5 millimeters, and she have more than 7 or 8 millimeter discrepancy. Actually, she have 1 centimeter to 11 millimeter discrepancy. So this is a lot to overcome with cantilever. So we decide, also because of her age, health, and of course the discrepancy, the severity of her class 3, to go for phase B. If we look here, why do we have this problem with the nose and lips? If we look here, we have those muscles, and we have a little muscles called the depressor septi nasis. So this muscle is situated from the tip of the nose to the orbicularis or to the anterior part of the maxilla, the origin. So when the maxilla is when the maxilla gets atrophied, this muscle actually pull the tip of the nose in when the moving of the face. So when smiling, immediately the lips drops up and the nose drops down. Okay. So before the operation, we examined the class 3 bridge, which will be used at time of operation. It's the same, it will be moved to class 1. Okay, it's the same occlusion, okay? You understand? I'll show it again. This is important, okay? Sorry. This is the same bridge without the cantilever in class 3, which we'll use in the operation, and the second bridge in class 1, which is have the same occlusion, which you use as transitional bridge. Thank you. Okay, so if you look at this, this is the class 3 bridge, and this is a class 1 bridge, the same occlusion, no buccal cantilever, that's all. So this is when she put the class 3 bridge in. Of course, she has a huge discrepancy, and this is overcome with a huge cantilever. So now we are ready for the operation, but before, we have to examine digitally how to do the operation, because today we do orthognathic surgery after we plan it in 3 dimensions. So we scan both the class 1 and the class 3 bridge, and then we prepare the virtual casting, and then with the CT, facial CT in class 3 and class 1, we can plan the operation. This was done by Plan Mecca. So you can see here, I don't know if you can see here the number, this is a 10 millimeter discrepancy between the class 1 and the class 3 bridge. We prepare everything in advance, the position of the osteotomy, the template that will be used to hold everything, the titanium template, the position of the screws, everything in advance. And we get these stereolytical models before and after the operation, the virtual operation. And if you look at the implants, we call it, actually it's implants, but the plates, look at the huge advancement that we are going to do for that lady. So this is just in the morning of the operation. The cephalometric view, I always take also a cephalometric view, and you can see her face just prior to operation. This is as I go to the operation and in the operating room that you saw in the first. So again, I harvest some bone marrow from iliac crest. We of course put some more implants after I take out the transitional implant, and then place the class 3 transitional denture. And this is how I do the operations, the Leaf-Fort 1. So we have a template for the osteotomy to be accurate. And after separating the maxilla, we use, of course, wafer to place the position. This is hard to see. And then I place the pre-prepared plates. Of course, we have huge discrepancies, so I use allograft to close the discrepancies, the 1 centimeter discrepancy, and this is a buccal pad of fat covering the entire augmented area and the entire operating area. So I use a lot of PPP as well, platelets, poor plasma, checking a little bit the occlusion, using the IMF only for a few days. This is just slight IMF, intermaxillar fixation. Actually, we leave her with an open mouth. So this is before the cutting, before the osteotomy, and this is after the fixation. If we look at the pre-prepared model, it looks quite the same. So we can get quite an accuracy due to 2 things. First, of course, the 3D digital planning in advance and preparing everything, the holes, everything in advance. And also we know exactly where the teeth are going to be because we had prepared in advance the position of the class 1 and the implants. So it's not an imaginary class 1, it's a real class 1 that did it accuracy. This is the preoperative without the prosthesis and the postoperative view of the same patient a month after the operation. This is a month after the operation. I want you to pay attention to 3 areas. Again, the tip of the nose, it's like she had a rhinoplasty. I didn't touch the nose at all. And then we have the nasolabial area, the cheeks here, and the upper lip in the right position, very nice position. If we just look at the cephalometric view, of course we work 3D digitally, but we give also it's very important to see it in 2D as well. This is how she came to me on the left. And this is after the operation, and in the middle it is after the augmentation procedures. This is pre, this is post-phase A, and this is after the operation, a month after the operation. She's still a little bit swollen. And if you look here in this tracing, you all know the dimension that we are looking at, the point A, which means the anterior nasal spine, which needs to be anteriorly than the point B. And we can see here that this is the reverse triangle here. Even after augmentation, we still have the point A in the posterior area because I couldn't overcome the discrepancy only with augmentation. And here with the Leaf-Fort 1 of 1 centimeter, which is a huge advancement, we get at last the point A to the right position. Let's look at the panoramic view. So we have here 9 implants. We don't look at the lower, okay? We can see the plates in place. And the important thing is the CT scan. So implants were placed a few months earlier, almost 9 months earlier. And now we can see the bone there, which was augmented a few months earlier in the augmentation procedure together with the implant placement. So you can see here that no angulation abutment were needed. It's a straight situation with no angulation abutment. This is the final abutment prior to the final prosthesis. So this is very important to see the amount of bone here and the position of the abutment. So we hope, of course, that this will stay for the long run. So I put enough implants also. So if you lose implants, you won't lose the entire work. This is the transitional prosthesis in class 1, and the facial scanning with this transitional prosthesis in class 1. I did not make an intention to overcome the entire vertical discrepancy, because I'm not worried about the vertical dimension, because you can overcome it very easily with pink prosthesis. Actually, I even like it higher because I don't like the interface of the natural tissues and the prosthesis to be visible. So I prefer it higher with a little bit of pink prosthesis in the vertical dimension. So most of the efforts were done for anterior, for advancement and not for down fracturing. And this is very important, especially in such huge discrepancy. We need to keep some connection between the bone for better healing. Okay, so we can see the pre-op scanning, facial scanning with her teeth, and the post-op facial scanning. Okay, this is with her teeth that I showed you to begin with. And look at the difference in her nose, in her upper lip and cheeks. So this what I'm talking about, facial aesthetic, due to the right position of the maxilla and the teeth. And without any temporary solution, just like injections of hyaluronic acid or etc. This is a final situation and a stable situation. Of course, when she gets older, she can use some fillers, whatever she wants, but the bone is in the right position. This is what's important. And this is what I'm trying to say. This is a pre-op with the class 3 bridge in location. And this is after a few months. Actually, you can see here also the nice cheeks she had and the lips, really nice, very nice aesthetic situation. And this is the pre-op with her old denture. So you won't say, okay, you put the class 3 bridge and now you show the class 1. Look how she came. And this is with the transitional bridge. And this is how she looks like. Thank you very much.
Thank you so much, Devorah. It was, I have to say, it was mesmerizing. It was not something, you know, that so many people maybe are not capable of doing it. It needs so much expertise and talent and, you know, knowledge and skills. But, you know, I personally had a great lesson out of this presentation that we should think comprehensively about a patient, and it's not just only about the function or only about the aesthetic. It's a package that we should deliver to the patient, and we should always, I think we always have the right to choose the right procedure for the patient, and not the one that is easier for us to do it, but the most proper one for our patient. So we should consult, and maybe sometimes we need to refer to the best possible option, a specialist that can solve the problem as you beautifully presented. So thank you so much for sharing these two great, amazing cases. I'm so excited to have so many questions from you, but you know, I want to keep it short. First of all, one of your research interests was on smoking. I know this question is not related directly to the topic of presentation, but I want to ask you generally because it's most of the audiences have these questions, not only in implant dentistry, but especially in augmentations that you showed. How do you evaluate the smokers if they want to choose these treatment options? Is smoking a risk for choosing these treatment options? Is it a contraindication, or how we should manage the case if they are smokers?
Mm. You have a lot of smokers in Iran?
Yes, we have.
Actually, I don't do this procedure in smokers anymore. I wrote a lot about the problem and the success of implant in smoking patients. So there are procedures that I do in smokers, but I do not do heavy augmentation procedures in smoker, not at all. If they don't give up a month before and forever, I do not touch them. If they come here, you know, I have a lecture, and I said, I don't care about smoking. Actually, it doesn't even bother me. I don't smoke myself, but it doesn't bother me. So I say to them, I'm not talking from a point of view of education, because you are your own decision how to hold your body and what to do with it. But I decide when I put my hands in your body, and when you smoke, I just decide not to do it. And we can drink coffee, you can smoke your cigarette, and we'll be nice friends, but I'm not going to be your surgeon. And when they hear it, and I really mean it, I don't care about education. I'm not a teacher. Well, I am, but not in this, in this situation. So sometimes they give up because it's very important for them. They feel like cripples because they cannot even hold the denture anymore. If you have really severe atrophy, even the denture is impossible to hold. And so that's my answer. I will not do it in heavy smoker. Yes, I will do 4 implants and zygomatic implants and all these kind of implants if they need, but not such a heavy augmentation procedure.
And you showed, especially in your first case, that you placed almost 10 implants in the posterior part. You did the subnasal augmentation, sinus grafting. And I noticed that there was a little amount of vertical bone loss in 6 years, but not affecting the outcome because you had a great soft tissue to hold the implants, especially in the crestal part. But one of the things that maybe be a question of so many of us is that, what do you think about using short implants and minimizing the procedures, doing vertical augmentations supracrestally? I mean, not subcrestally, but how do you see using short implants and having longer crown heights in those cases?
Okay. We're not talking about those cases. In severe atrophy, you cannot place implants, period. Okay. With the years, we believe more in short implants. So I will not say don't use short implants. We don't have still very long run follow-up on short implants, but I think we have good results with them. So it's not one against the other. It's in cases with severe atrophy when there is no other solution for implants. If you ask me why 8 to 10 implants, and then because I would like to say this is a very risky situation, and I don't want to go back to those patients. I want to do it once. And I said it before, I prefer to do 8 to 10 implants and lose some on the way. I have a lots of experience. I lose 1 or 2 with the years, but mostly they stayed. But yet 6 is the minimum, and 8 to 10, I think, is the optimum. So we said about 8 implants. It depends also on the patients. If the patient is a tall, heavy guy, I would definitely do 10 implants and give him the opportunity to eat whatever he wants. But if it's a very soft lady and she's an old lady, I'll go for the 6. You know, you have the ability to think. Those the patients that I showed, one was 54 years old and the other was almost 40. So it's a different, we have to think about 40 years in advance or 20 to 30 years in advance. I won't be there to change it, but, but, but still I want her to say I had the good doctor.
Yeah, sure. You know, Devorah, you showed placing in, you know, doing the sinus grafting, subnasal augmentation, implant placement at the same time, and do the block grafts in horizontal ridge augmentation. You know, so many things there with materials, with autogenous graft, you know, implant itself. So do you see any concern regarding vascular supply in such cases that you do everything together in your experience?
This is an excellent question. This is two answers. First of all, I believe that less surgeries is needed. So when I plan surgery, I plan a lot to do in the same time, because I think it's not a healthy situation, get the surgery. So I do a lot in the same. So we have to plan it in advance and do it in the right way. So about the vascularity, I show two things, two important things. When I use bone xenograft material, I use always blood materials, either PRP or PRF. I don't use PRF so much, I use PRP, but in those cases, I prefer bone marrow. Bone marrow, and I saturated everything in bone marrow. This gives better vascularity. And then I showed the buccal fat pad, pedicle graft, which gives the vascularity. So I'm a lot concerned about the vascularity because it's an atrophied jaw. That's why I don't do the Leafort one as a first stage, because a segment, if it's very thin, and it moves forward and downward, and then even if you use, as we used to do in the past, a horseshoe taken from a horseshoe inlay graft from the iliac crest or allograft or whatever, it will be too risky. So first I do the augmentation procedure, put the implants. I don't see any problem with this. I never had problems of vascularity. It's not that I got 100% success with the implants. I lost an implant here and there, but not more than this. The procedure itself, if it's done properly by skilled hands and used it as you need to know surgery to do it, then it's a safe and predictable procedure. Subnasal elevation procedure, sinus elevation procedure, and onlay bone graft with implant placement are safe procedures.
Yeah, exactly. And you know,
can be done in one procedure.
Yeah, you know,
and we know it. Not only me. This we have for years experience. Exactly. The problem is that it's not enough.
Yeah. So, you know, you talked about buccal fat pad, and, you know, we know that it has stem cells, and, you know, it provides a great environment for healing. And it's one of the interests, especially for maxillofacial surgeons, especially in the cases that maybe they think that there is a risk of flap opening, or, you know, they want to maximizing vascularity or regeneration. But I want to know your experience. I mean, you're an expert, so I'm pretty sure your answer will be no. But for those who are beginners or they want to learn more, is it a risky area for bringing the buccal fat pad in the area of the procedure? I mean, is there any risk for harvesting or having that pedicle buccal fat pad, or it's a safe area anatomically?
Yes, we need to know anatomically, because actually it's not harvesting, it's pulling, because it's a pedicle graft. It's very important. While you penetrate, there are, of course, blood vessels there, and there is the canal of the parotid duct. If you go too much peripherally, you can go into it. So you need to know the anatomy very well and go into the pedicle graft, and then you just pull it. I take a mosquito, for instance, a very long one. I penetrate the buccinator, catch the buccal pad of fat, open it, and then pull it over. It must be very knowledgeable and skilled way to do it. And I wouldn't recommend to do it without an oral surgeon around.
Yeah.
Not to begin with. You can learn everything. I learned too, and I teach everything. And you can do residency. Of course, I wasn't born knowing how to do pedicle graft. You learn it. As you know, I always say to dentists that I teach, because I teach only postgraduate now, that everyone has to have a desire to widen his envelope of knowledge. So it's very important. So that's why we give so many lectures. And actually we have a course on onlay bone grafts. And when the sky will be open, you are invited to those courses. We cannot do it online because you need really to try it on. So the theoretical part maybe, but not hands-on. So everything can be learned and tried. But this is a good question. Don't try it at home without first learning how to do it.
You know,
Bleeding. Be aware.
you know, your topic was so interesting, and I know that we can talk about it for many hours, but you know, your time is precious and limited. So I want to keep it short. And I just want to know one last thing. Actually, you mentioned it, but sometimes there are some patients that won't accept to go through the second phase, phase B. You know, they want to keep it simpler, maybe from the financial point of view. Sometimes they're afraid of doing surgeries, you know, for those kind of patients. Do you think that using fillers in the lip, because you showed that when they smile, we have this wrinkle here. So in those cases that will not accept to go through phase B, do you recommend using fillers to compromise the aesthetic results or not?
Unfortunately, if the discrepancy is so big, you cannot do fillers. You get ducky lips. Mm-hmm. And this is really unpleasant, that these ducky lips. Today, we see less and less those situations. With hyaluronic acid, you have to do it every few months, and it's not enough. If the discrepancy is smaller than 5 millimeters, then you can do other things. So I said in the lectures, and I repeat it now, the indication for Lefort-1 should be huge discrepancy, huge atrophy, severe atrophy. And you have to give it in advance. Also the financial, how much it's going to cost you for the first operation or for the second operation. If it doesn't fit, maybe you have to choose another method to give and to do things that are differently, like we did in the past. We did a lot of augmentation procedure and implantation and fixed prosthesis without taking care so much about the upper lip wrinkle or the smile or the position of the lips. But if we go in forward, and if you go with facing forward, we have to think differently. And of course, not 100% of the patients that I give this option will take it. And I have an option for sometimes if the resorption is not so severe vertically, we can do all in one. It means implantation and immediate loading, of course, and Lefort-1. But this is a very rare situation. Usually you need 2 operations. And this is also a disadvantage. But still, let's just think about facelift. Facelift, would you say the same question? Would you ask the same question? How many people are doing facelift today? This is much harder operation. And a change is much bigger. And people don't think twice before they go to the knife of the operation. So you have to think differently about oral and maxillofacial surgery. We have to think it as part of our facial aesthetics. We are not going to stay in hospital for a few days. It's just overnight. And in the morning you go home. There are no scars, no problem with your facial, and you still get some kind of facial aesthetics. And this is permanent. So as you think about facial aesthetics, now you can understand my point of view.
Exactly right. Exactly right. Devorah, thank you so much for your messages, for your time, for sharing to all of us. I personally truly enjoyed it. I'm pretty sure all of our audience did, and truly appreciate it, my friend. Hats off. Hopefully this situation, the COVID, ends soon when we have the chance to travel and meet each other soon in person again. God bless you.
Thank you, Omid, and thank you, audience, that I haven't seen you, but I hope to see you soon. Good night.
Good night.
Thank you. Thank you.
Take care.
Bye-bye.